Hello, my name is Dr. Lori Worth, and I am the medical director of the Center for Head and Neck Cancers at Massachusetts General Hospital in Boston in the United States. I'm joined today by Ms. Tara Hurley, the lead research nurse at the Head and Neck Oncology Unit at the Royal Marsden Hospital in Sutton, UK. Welcome, Ms. Hurley. And also by Dr. Antonio Matrone, a researcher in the Unit of Endocrinology at the University of Pisa in Italy. Welcome, Dr. Matrone.
Thank you.
And by Dr. Peter Sadow, Director of Head and Neck Pathology, also at Massachusetts General Hospital in Boston. Welcome, Dr. Sadow.
Thank you.
In this section, we will address thyroid cancers in context, epidemiology, treatment options, and the role of the multidisciplinary team. So, Dr. Sadow, how about if you walk us through the main types of thyroid cancer and just a touch on the epidemiology of thyroid cancer?
Sure. I think people typically think about the well-differentiated thyroid carcinomas when they're thinking about thyroid cancers. But in this day of molecular era, we are actually learning a lot more that our thyroid cancers are a lot more distinct than we typically have given credit for. So we typically think about the most common type of thyroid cancer, which is papillary thyroid carcinoma, and another type of thyroid cancer that people are fairly familiar with, which is follicular thyroid carcinoma. And then we can start talking about more rare types of cancers that people have also heard of, anaplastic thyroid cancers and medullary thyroid carcinomas, and then some of the more weird forms that fall somewhere in between.
So in terms of the types of thyroid cancer, as you mentioned, papillary thyroid cancer is the most common type. We know that frequently harbors a BRAF V600E mutation. Do you think that, and then follicular thyroid cancers, the second most common type, are often driven by NRAS or HRAS mutations, just as examples of the more common driver mutations. Do you think, Dr. Sadow, that in the future, rather than thinking about papillary, follicular, poorly differentiated, that we're going to be talking about thyroid cancers based on the driver gene alterations?
Oh, absolutely. And I'll tell you that I have several emails that have gone back and forth this weekend. The new WHO classification of endocrine tumors is coming out, and actually even discussing these lesions by email in terms of the final product. We're fighting because it's really molecular driven. And so we're talking about how to classify which entities and which categories to put them in. And the arguments we're currently having are over genes and how we actually denote these tumors and what category should they fall in. So 100%, we're moving away from these sort of classical definitions and moving toward a combined morphologic and molecular definition.
So we mentioned BRAF V600E mutations, NRAS, HRAS mutations. What are the other driver alterations that we're interested in from a treatment point of view and prognostic point of view? And then where do we see those alterations?
Well, it is, quite a challenge for us. As you mentioned, BRAF V600E is the most common mutation in papillary thyroid carcinomas. And wonderfully, we actually have an immunohistochemical stain, which is very inexpensive to perform, where we can actually rule that in or rule that out kind of immediately when we have a cancer. So we can rule that, as the causative agent. It's particularly when that mutation is absent, then we start thinking about other drivers. And the other drivers oftentimes are associated with fusion proteins that we see. And there's a number, of course, the more tumors we test, the number of different partners we see. But the common scenarios we're starting to see are things like RET fusions and NTRK fusions, and of course the subtypes of those. We're really actually doing a really good job trying to figure these things out. But of course, we only find them when we look for them.
That's a good point. And then just, I'm glad you mentioned RET fusions and NTRK fusions. I think we don't want to give short shrift to RET mutations that are drivers in a significant portion of medullary thyroid cancers as well. Yeah. And then the other thing I think that's important to note is that BRAF V600E is targetable, but we don't necessarily think of BRAF-directed therapies as first-line therapy for advanced papillary thyroid cancers, but it's very pertinent because of the activity of targeting that therapy in anaplastic thyroid cancers. Dr. Matrone, in terms of unmet treatment needs, I'm hoping that you can comment on the unmet needs when we see progression to metastatic disease in our patients with thyroid cancer, and then also resistance to standard treatment options?
Yeah. In this type of patients, it is important to define when starting with the systemic treatment, because not all patients with advanced thyroid cancer needs to be treated with systemic treatment. So when we see at least now, the progression of disease and really important progression of disease, mainly according to RECIST criteria. And so we should think to begin the treatment, the systemic treatment. Obviously, we have at least in Italy, multikinase inhibitors as a first-line treatment, both for differentiated thyroid cancer, that for medullary thyroid cancer. And but we know very well that because we performed the phase 2-3 study in the EXAM trial, the ZETA trial, the phase 3 study of cabozantinib and vandetanib, that we know very well that these patients sometimes often during their lifetime and their treatment progressed under multikinase inhibitors. These are drugs that are a very good function on the control of the disease, but these patients, at least we have with vandetanib, for example, I can share with you our data in PISA that these patients after 4-5 years of treatment progressed, and that this time this is let's say a resistance to the treatment, and when these patients progress, it is important to have new arrows to begin a new treatment. And these cases, probably the highly selective RET inhibitors are very important. Also, if we can consider that about 20% of medullary thyroid cancer had no driver mutation, and this patient is very difficult to perform the management.
What do you think about the unmet need in terms of the toxicity profile of our current available therapies for patients with advanced thyroid cancer?
Yes, we know very well that these drugs have multiple sites of action because they were designed to mainly target the vascular endothelial growth factor receptor, and suppress the angiogenesis, but also influencing other kinases. And also, if these molecules really changed the story of thyroid tumors, in which conventional therapy or chemotherapy are less effective, and their use in some cases improve the disease-specific survival. On the other hand, both for differentiated and medullary thyroid cancer, we have the off-target toxicity that are manageable in most of the cases, but sometimes they can limit the clinical utility of these drugs.
Ms. Hurley, in your experience, what have you found in terms of the impact on patients with the side effects that we encounter with the multikinase inhibitors?
I found they can vary hugely. They're very individual from patient to patient, although you tend to find themes in amongst multi-targeted TKIs. So generally a theme within them is there's hypertension that many patients suffer from. So it's about developing a management strategy for that in a timely manner so that they don't have to enter dose interruptions, dose reduction territory. And we often involve cardiology, so envelop a multidisciplinary approach outside of general oncology, endocrinology for thyroid patients. We often see very much more physical impacts such as diarrhea, especially in medullary thyroid cancer, where you've got rising calcitonins. And actually that can be really, really quite debilitating for our patients. So if you can assure a confidence in the patient that they're able to tell you about something that can be somewhat embarrassing for them, unfortunately, although you try and maintain open channels of communication, these things can be really difficult for our patients to mention to us. So it's just about advocating that there is no issue too small. If you notice any change in your patterns, whether it be diarrhea, urination, any skin changes, they highlight it to us at the earliest opportunity.
And on that note, perhaps I can ask Dr. Matrone to comment a little bit on the new and emerging treatments in the gene-specific realm.
Yes, the improved knowledge about the molecular profile of patients with thyroid cancer in the last years led to the development of new, highly selective molecules against specific mutation of the cancer. So nowadays, I think that we are getting familiar with the new concept of agnostic treatment. Okay, that consider not more the histology, but prevalent the types of mutation that a tumor carried. And these mutations are considered as actionable. That means that a specific drug is available against them. And so we have several emerging treatments, targeted treatments that are called selective tyrosine kinase inhibitors. And we in Italy, probably in a few days, cepercatinib and pralsetinib will be available in the, not only in the clinical trials, but in the clinical practice. And we have several molecules that are useful for several types of cancer, such as pralsetinib and cepercatinib, that are tried in the clinical trials and that are highly selective RET inhibitors against RET mutant and medullary thyroid cancer and RET fusion positive lung cancers, but in our field, thyroid cancer. And very impressive results are also those of dabrafenib and trametinib, and in particular for anaplastic thyroid cancer, because we know that we can use these drugs also for papillary thyroid cancer with BRAF mutation, but the response in papillary thyroid cancer are not so good, while are impressive in the anaplastic thyroid cancer. Also, before surgery, so in an adjuvant, neoadjuvant treatment for after treat these patients with surgery. And very important results are also those with the larotrectinib. And Dr. Cabanillas showed this data about the larotrectinib some weeks ago. And the objective response rate was higher, about 75% in patients with papillary, follicular, and also anaplastic.
Great, thanks for your comments. Let's talk very briefly about the role of the multidisciplinary approach to thyroid cancer. But now I think we have a really robust multidisciplinary approach with the pathologist playing a critical role. Our surgeons are always going to be very important, endocrinologists, medical oncologists, and then also research nursing and nursing support as well for taking care of these patients with complex disease. Dr. Sato, can I just ask you very briefly to comment on what you see as your role in the multidisciplinary approach as a pathologist?
Absolutely. I think the most important role we have is screening these patients. So once we actually have surgical material from these patients, we screen for BRAF. If BRAF V600E is actually not the primary causant, then we actually go for it in terms of looking for these fusions, which are targetable. And as you mentioned, the surgeon's exceptionally important to us. And how we view the surgeon being important is they're a consenter. So the pathologist who doesn't actually have direct access to the patient, we call the surgeon, say, please consent your patient. We need to do molecular testing, especially as you've mentioned for RET mutations, because for the fusions, we don't need patient consent because they're somatic changes. But because doing mutational testing can identify patients having germline mutations, the patient does need to consent to that. So we step one is BRAF mutation. Step two is looking for other changes, and we absolutely do that essentially in every single case.
Let me just ask one last question on the MDT setting of Ms. Hurley. In terms of patient involvement in this decision-making process, how do you see that?
I think it's a huge part of how patients progress with their treatment. I think patient advocacy is a huge part of my role, and also involving their caregivers and their support network as well if they want them to be part of that. I think as long as you have their engagement, you'll gain trust in these treatments, and that the side effects can be managed, because I think a lot of it comes down to that no treatment is without effects at some point or another, whether silent or very present outwardly. So I think patient advocacy, patient involvement is huge in just their longevity of remaining on these therapies. and also just feeling well and giving them the quality of life that they deserve whilst they're on these treatments as well.
Very good points. Thank you. And with that, I'd like to thank our faculty for participating in today's meeting, and also thank the audience very much for your attention.
Hello there, my name is Dr. Peter Sato, and I am the Director of Head and Neck Pathology at Massachusetts General Hospital in Boston, Massachusetts in the USA. And I'm joined today by Dr. Antonio Matrone, a researcher at the Unit of Endocrinology at the University of Pisa in Italy. Welcome to you, Dr. Matrone.
Thank you.
And by Dr. Lori Worth, who is Medical Director of the Center for Head and Neck Cancers, also at Massachusetts General Hospital. Welcome to you, Dr. Worth.
Thank you.
Thanks. In this section, we're going to focus on a personalized approach to treating thyroid cancer, biomarker testing, and its influence on patient outcomes. So we're going to start off by discussing precision medicine as a fast-moving field within thyroid cancer. And I'm going to shift to you, Dr. Matrone, to tell us about this importance in treating thyroid cancers.
Yes, this is an important point in treating thyroid cancers, because we have the precision medicine that probably start not only from the molecular diagnosis of this cancer, but probably the precision medicine started from the decision to perform fine needle aspiration on these nodules that are really suspicious for thyroid cancer. And after this, the precision medicine continues to have a right surgery, and often less invasive, and less radioiodine treatment, always more selective. And after this, obviously, for the advanced types of thyroid cancer, it is very important to have the complete molecular profile of thyroid cancer, because this characterization is really important for the treatment of the advanced cases.
And the other thing I wanted to mention, because I'm going to shift in a second to Dr. Worth, but I'd like you to comment from the perspective of a European perspective, an approach to precision diagnosis, because in the United States we have, and Dr. Worth will discuss this, various sort of specific protocols about how we go about testing thyroid nodules, and subsequently, what is sort of the typical approach for precision medicine in Europe?
Yeah, I think that in USA the approach is very different from those we use now in Europe. We know that we have you have two main systems for the preoperative molecular characterization, particularly of the indeterminate thyroid nodule, so the class 3 and 4 Bethesda classification system. But we in Italy and in Europe, we have neither Afirma nor ThyroSec. For our patients, the potential use of this system is highly expensive, because they are not covered by the insurances. I can tell you our experience in Pisa. Also, if not regularly, we perform the molecular characterization of not all, but a good part of the indeterminate thyroid nodules for the detection of point mutation of RAS gene and the BRAF gene. But we know very well that why we perform a selective approach for these nodules, because we know that at least in the indeterminate thyroid nodules, the presence of BRAF is quite rare. And RAS mutations are present also in benign nodules, such as follicular adenoma. And also RAP-PTC and NTRK fusions are quite rare. Therefore, if we have the patients that are negative for driver pathogenic mutation of cancers, what does the molecular analysis add to these patients? So for these reasons, at least in our hand, the clinical behavior, the ultrasonographic features of the nodule, and a good cytological evaluation remain at now the main tools in management of indeterminate thyroid nodules.
Interesting. So that really brings us to something that I'd like to cover next, which is sort of an overview of the biomarkers. And I'd like to bring in Dr. Worth for this, because it also affects the way we approach these tumors or nodules preoperatively and postoperatively. So Dr. Worth, I'd like you to sort of give similar comments from a perspective of how we approach these in the U.S.?
I'm fortunate to work in a center that has excellent ultrasonography, excellent cytopathology. I think in the U.S., one of the important roles in preoperative nodule molecular diagnostics is for patients that are being treated outside of centers that have really excellent clinicians that can make those clinical determinations on the features and don't necessarily need to have the molecular characteristics of an indeterminate a Bethesda 3 or 4 in order to know whether that patient should have surgery for that thyroid nodule or not. And so we do, I think, in the US find that there is a utility in the molecular diagnostic procedures for the initial workup of thyroid nodules, particularly in centers that don't have large volume practices that and really excellent clinicians at every level of the analysis. But I think I like where Dr. Sato is going with the fact that beyond making a diagnosis of a thyroid nodule that is suspicious enough for cancer that it needs to be operated on or not, there is in many cases an emerging utility, I think, in understanding the molecular characteristics preoperatively, particularly for patients that have very bulky disease. We're now beginning to explore neoadjuvant targeted therapy for patients who present with bulky thyroid cancers in order to not just make their surgeries more feasible by debulking the disease with systemic therapy when available, but also in improving surgical outcomes. We are launching clinical trials, for example, exploring neoadjuvant pralsetinib and other neoadjuvant gene-specific therapies that will provide therapy to debulk patients who present with very bulky RET mutant positive MTC or RET fusion positive DTC or even anaplastic thyroid cancer. So patients can have better surgeries and better morbidity following the surgery.
That's great. And the other thing that I wanted to mention briefly is some of the methods used to detect the presence of biomarkers. And Dr. Matrone had mentioned doing targeted testing for BRAF and for RET specifically, which isn't necessarily helpful in their cases for indeterminate nodules. And we use a number of methodologies too, and depending on what hospital you're at, things are readily available. For instance, we don't have a lot of the markers to do for FISH analysis. So when we test for fusions, we're typically looking at NGS sequencing for these fusion assays, which they're more expensive and they take a longer amount of time, but we don't actually have the individual tests because, as we were discussing earlier, some of these findings are fairly rare. So it has to be cost effective, and you have to maintain antibodies, and you have to have, well, it's mostly a cost issue. So for immunohistochemistry, we will use a BRAF V600E antibody, which is a great screening tool, and that's about all we use for immunohistochemistry. There are some RAS antibodies that we don't particularly find useful. There are some FISH tests for NTRK that we also find to be fairly non-specific. So we tend to do NGS for looking at these tests, but it's very different. So Dr. Matrone, do you have any comments about the types of testing that are available for your patients?
Yes, I can tell you about our experience in PISA, where at now we use next generation sequencing, but in the previous years we perform immunohistochemistry that, as you know very well from the result of several series, showed a quite good result also in searching NTRK fusions, and particularly also with BRAF point mutation. My molecular biologist often say that PCR and FISH in expert hands could provide a good results. However, these techniques show some technical limitation, probably mainly related to the lack of resolution for some functional details. But my molecular biologists at now we use a next generation sequencing because we can check several gene mutations or fusions of different cases at the same time with an improvement of working time and costs. And the fusions can detect it also by DNA or RNA sequencing. Also, if there are also in this case some technical issues in peculiar cases for RNA, and as you know very well. In PISA, we use a next generation sequencing with a self-made custom panel for testing advanced DTC, poorly differentiated anaplastic, and all MTC cases.
Perfect. And the last thing I wanted you both to comment on, and we can start with Dr. Wirth, are how personal medicine influences patient outcomes. And you know, Dr. Wirth has been running several major trials with these tyrosine kinase inhibitors, and with greater and greater specificity. And I thought maybe you could talk about some of the issues that you're encountering with these multi-targeted tyrosine kinase inhibitors and some of the advantages, you know, according to the patient's mutational status.
So we do have very good multi-kinase inhibitors that have good activity in iodine refractory, progressive, differentiated thyroid cancer, and in medullary thyroid cancer as well. In the US, we have lenvatinib, sorafenib approved. For DTC, MTC, we have vandatinib and cabozantinib approved. All of these drugs really have good activity with good response rates, good progression-free survival, durable responses. There's a common feature, however, with the multi-kinase inhibitors, which is the side effect profile that patients experience. Patients are often on these drugs for many, many months, and they can experience side effects on a daily basis. And those side effects are not negligible. Hypertension is common, diarrhea, hand-foot syndrome, fatigue, weight loss. Those can significantly impact on a patient's quality of life. And this is different, we're seeing, with the gene-specific therapy. So for patients that have RET fusions, RET mutations, or NTRK fusions, we now have in our arsenal RET-specific and NTRK-specific therapies that are FDA approved in the United States. These drugs also have really good efficacy, very high response rates, long progression-free survival. In fact, so long we haven't even figured out what the median progression-free survival is in most cases, very durable responses, but also very good adverse event profiles overall. We do see some toxicity, but it's mostly on-target toxicity that's manageable, usually grade 1 and grade 2. It's very uncommon that we have to stop the gene-specific therapy due to toxicity of the drugs.
That's awesome. So I think this is kind of a great, you know, so overall background that we're quickly going to go through one case scenario. And this case scenario that I'm going to present to both of you is a male patient who's 57 years old with medullary thyroid carcinoma. So 57, you know, these days is a baby, but we'll say a middle-aged person, a middle-aged person, 57 years old, who initially tested negative for a RET germline mutation. And then the medullary thyroid carcinoma became metastatic. So we performed a next-gen sequencing, and the patient tested positive for somatic RET mutation in this tumor. And so, so what treatment approach would you take with this patient? And we can start off with you, Dr. Matrone.
Yes, in this case, I think that there are two questions to ask. How big is the tumor burden? And how quickly the disease progressed over time. This is very important point, because the presence of RET mutation is clearly important, but it is, in this case, probably it is more important to evaluate the tumor burden, because we can treat these patients, in our experience, also with local therapies, and after to evaluate the rate of progression. Moreover, we know that the presence of RET mutation allowed us to the use of highly selective RET inhibitors, but the availability of this drug, at least now in Italy, is also in clinical trials. So we have the first line approved treatment, vandatinib and cabozantinib, and after we can enroll the patient, or we can enroll the patients in the, let's say, Libretto 531 study. And so I think that if these patients show a real progression, we can think to start the systemic treatment. Or also in this case, the active surveillance should be an option.
Dr. Wirth, what about you? How are you going to tackle him?
I'd like to go back for a second and point out that I'm really glad that you did germline testing in this 57-year-old patient. Every index case of patients with MTC really does need to have a germline RET mutation ruled out, not only because of the implications for the patient, but also the patient's first-degree family members. So I'm glad that we have that detail in this case. It's important to highlight. And I agree again with Dr. Matrone that it's important to know the pace of the disease. It's so interesting how there really is a wide natural history in medullary thyroid cancer. And so we really want to know the flavor of the disease at the time that distant metastatic disease is identified, to know how quickly is or slowly is the patient going to be progressing. We don't necessarily want to pull out our best weapon initially if the patient is going to remain asymptomatic and have very slow growing disease. If, however, there is meaningful disease progression, then therapy is warranted. In the US, we do have selpercatinib and pralsetinib, both FDA approved in the line agnostic setting for RET altered thyroid cancers, including RET mutant MTC. I would, however, also like to endorse encouraging the audience to enroll patients in clinical trials. The Libretto 531 trial was mentioned. There's also a pralsetinib randomized phase 3 trial that we should mention.
That's awesome. And I just like to take this opportunity to thank Drs. Wirth and Matrone for their outstanding insight that they've been able to offer to us, especially as we start thinking about, as we discussed over the course of the last several minutes, about our approach to molecular diagnostics. What is the role of preoperative testing in terms of both for neoadjuvant therapy as well as for therapy in patients with advanced thyroid cancers? So I think it was really, really helpful, a really lively discussion. I appreciate everybody's participation, and thank you all for joining us. Thanks.
Hello, my name is Dr. Antonio Matrone, and I'm a researcher in the Unit of Endocrinology at the University of Pisa in Italy. And I'm joined today by Ms. Tara Hurley, lead research nurse at the Head and Neck Oncology Unit at the Royal Marsden Hospital in Sutton, UK. And by Dr. Lori Wirth, Medical Director of the Center for Head and Neck Cancer at Mass General Hospital in Boston, USA. Welcome, Dr. Wirth.
Thank you.
In this section, we will be considering the question, what do the latest clinical data for targeted therapies tell us about the prospects for patients with thyroid cancers? So we will point out the latest efficacy and safety data for the new highly selective targeted therapies available. But first of all, for all the audience, I want to underline that unfortunately at now, some of these therapies we are talking about are not fully available in all countries. And this problem that I hope it will be overcome in the next months could limit their use in the management of advanced thyroid cancer patients. Since these molecules are developed in the last year, several data have been only recently published. And the first data that I want to share with the audience and with my expert panel, Dr. Wirth and Ms. Hurley, are the results of the studies of patients with thyroid cancers treated by pralsetinib and selpercatinib. And these are two new highly selective RET inhibitors, which can target both RET mutation and fusions. For this peculiarity, they are used in the RET fusion positive non-small cell lung carcinoma and thyroid carcinoma, and in RET mutation positive medullary thyroid carcinoma. And in this talk, we focused our attention, obviously, on thyroid cancer patients. If we look at pralsetinib, we have the results of the ARROW phase 1/2 trial. And the data have recently published in Lancet Diabetes Endocrinology. The main outcome of phase 2 study was the objective tumor response rate. And that means that the complete or partial response according to RECIST criteria. In the phase 2 were included 122 MTC patients and 20 RET fusion positive thyroid cancer patients. In the previously treated medullary thyroid cancer, objective response rate was 60% with a complete response in one single case. And this response, and I think this is very important, was independent by the RET mutation carried. In the naive MTC group, objective response rate was 61%. And in RET fusion positive thyroid cancer group, objective response rate was 89%. Similar results were experienced with the use of selpercatinib, in which we have 142 patients with RET mutant MTC and 19 with that RET fusion positive thyroid cancer. And objective response rate in RET mutant MTC patients previously treated was 69%, 73% in naive MTC, and 79% in RET fusion positive thyroid cancer. Please, Dr. Ward, can you give us the point of view of the oncologist and your point of view when you visited with these results in clinical practice?
Oh, thank you for the question. I have to say that these results with both selpercatinib and pralsetinib were very exciting to see when initially presented. These drugs work as they were designed to potently and specifically inhibit RET driving MTC and a subset of follicular-derived thyroid cancers. The responses that we see are usually early in the course of therapy. Often patients are responding after their first or second restaging periods. The responses are deep, meaning that we see a significant degree of tumor shrinkage, not just barely 30%. And we're even seeing patients with complete responses, particularly in the Libretto 001 trial. Those complete responses are always good to see for those individual patients, but I think it also means that we have drugs that are highly effective, and perhaps we need to do further exploration in how we are using these drugs. So we know for patients with advanced metastatic disease, there's clearly clinical benefit, but can we bring these drugs earlier into the course of treatment for patients in order to perhaps increase the cure rate for initially treated patients? For example, can we use a drug like selpercatinib or pralsetinib in patients with medullary thyroid cancer who've had a complete resection but have rising calcitonin and CEA with rapid doubling times? We know that those patients are destined to recur and have a significant disease-specific mortality.
The real news, I think, of these highly selective drugs seems to be the improvement in the safety profile if compared with the multikinase inhibitors. And if we look at the data of Arrow trial and the Libretto 001 trial, we know that the adverse event, the profile of adverse event is different from that of a multikinase inhibitor. And we have that adverse event of any grade where for pralsetinib, anemia, and musculoskeletal pain and constipation that are present in more than 40% of the patients. And those was decreased in 44% of patients, and 54% of patients experience a dose interruption. And I think that the slightly better data were shown with selpercatinib treatment, in which the adverse event attributable to the drug are mainly of grade 1 or 2. And when we consider all the patients enrolled in Libretto 001 trial, so not only thyroid cancer patients, we see that only 2% discontinued the treatment. And I think that this is a very important data. And according to this safety data, I would ask to Ms. Early to share with us her point of view about the improvement of adverse events experienced from the patients in this trial, particularly if compared with those of patients with multikinase inhibitor treatment. The nurse specialists, I think, represent the first and more important, bridge between patient and doctors. And they often have the first clinical approach with the patients. Please, Ms. Arlo.
Yes, we've certainly seen changes in the way patients are presenting with their adverse events. So we've moved away from seeing many more physical side effects, such as potentially diarrhea, skin toxicities, even hypertensions to an extent, and we're very much focusing more on reviewing the blood results, namely hematological and biochemical responses. So we've seen some patients presenting with grade 3 hyponatremias, which actually we didn't see incidentally in some of the earlier tyrosine kinase inhibitor therapies. So we've had to dose interrupt and reduce on the basis of that, but actually with very, very positive results and still an ongoing response on selpercatinib in terms of radiological response, which was really fantastic. And certainly in the clinical trials that we're working on, we're seeing certainly a drive in patients being seen more often
for hematological and biochemical review. It's actually inherently in the protocols. So I think we've certainly moved from patients actually living well on these diagnoses, on these treatments, and improving their survivorship with these therapies also, and equally with the amazing radiological responses that are being seen for many, many patients.
So I would share with you also some data about larotrectinib, that is a selective inhibitor of NTRK fusions. And at now, 2 single-arm clinical trials explored the role of larotrectinib in patients with thyroid cancer. And in particular, in a pooled analysis were included 28 patients with NTRK fusion-positive thyroid cancer, 19 with papillary thyroid cancer, 7 with anaplastic, and 2 with follicular thyroid cancer. And the preliminary data showed a real good objective response rate of 75% with larotrectinib, that is higher among patients with differentiated thyroid cancer, 90%, and lower, 29%, in those with anaplastic disease. But the exciting findings, if we look at the adverse event experienced by the patients who perform larotrectinib, grade 3 adverse event occurred in 32% of patients, and grade 4-5 in 7% of patients, but none of these adverse events were treatment-related. In fact, most of the treatment-related adverse events are grade 1 or 2. And this is a very important new drug for the treatment of those patients who carry the NTRK fusion. About entrectinib and selitrectinib, the other drugs with that targeting NTRK fusion, we have a few data available at now. But in the data we have, the drugs showed an objective response rate of about 50%, both in entrectinib and selitrectinib, with a favorable safety profile. And another question for Dr. Wirth, could you share with us your experience with these new drugs?
So we have had both the larotrectinib and entrectinib trials open at our site, and I have treated patients on both trials, and the efficacy is fantastic with both drugs, and the safety profile is as well. One thing that again is a theme in this gene-specific therapy is that we are beginning to see the emergence of acquired resistance. Again, the theme is that we often see mutations that arise in the kinase domain of the protein in the solvent front or in the gatekeeper site. And so selitrectinib is a second-generation NTRK inhibitor that was designed to overcome those acquired resistance mechanisms. So while the early data suggests that we're seeing overall response rates that are not quite as high as we see with larotrectinib, that still is in a patient population that has progressed on an NTRK inhibitor previously. And so with second-line therapy, those response rates are still pretty encouraging. So larotrectinib is very well tolerated. Most of the treatment-related adverse events are grade 1 and grade 2, and patients generally tolerate them well. I think most commonly we see mild fatigue and very mild dizziness is not uncommon. But for grade 3 or higher treatment-related adverse events, they're very uncommon with larotrectinib. With entrectinib, again, most treatment-related adverse events are grade 1 and grade 2. We do see some dysgeusia or taste change, mild fatigue, some constipation, a little bit of peripheral edema can be seen. And again, mild dizziness is not uncommon with entrectinib. And then lastly, with selitrectinib, I think that we do see a little bit more dizziness and ataxia with the second generation TRK inhibitor. And some other side effects are a little bit more common: nausea, vomiting, some bone marrow suppression, myalgia, fatigue, as seen as well.
Okay, thank you very much. And last question for Ms. Harley. How do you manage these side effect of these targeted therapies? So your point of view of the point of view of nurse specialist.
I think there's a huge aspect in empowering the patient to be aware of the changes in their body. So if they are noticing dizziness or ataxia, just ensuring that they're mindful of that they don't rush to stand. Equally, that on a physical level, we're checking that their blood pressure is within limits, and just being mindful in raising awareness to that. And equally with symptoms such as fatigue, just obeying their body a little bit. If they're feeling tired, have a rest, but equally encouraging them to promote their exercise tolerance, because equally that can improve fatigue and overall sleep overnight, reduce the risk of insomnia. With physical symptoms such as dysgeusia, diarrhea, constipation, there's many over-the-counter and prescribable methods of medication that we can use. And often it's about adaptation to the level of the grade of the symptom that the patient has. Sometimes you do need to interrupt the medication, but if you can do things such as promote different types of food that the patient wouldn't find had an altered taste to them, and eating little and often those small methods can actually help quite significantly. And with things like diarrhea and constipation, using the appropriate medications such as loperamides for diarrhea, laxatives for constipation, and just keeping on top of that, and also reviewing what other medications they might be on alongside those, because equally they could be added to these side effects.
I think that we can conclude this section with the discussion point about patient case studies. And we have the first patient, that is a male patient of 62 years old with metastatic RET fusion positive thyroid cancer. And he experienced 3 multi-targeted kinase inhibitor therapies. And when we have a progression of disease of these patients, what are the treatment options and key considerations for these patients? Dr. Wirt.
So for a patient that harbors a RET fusion and has had 3 prior multikinase inhibitors, I'd go straight to selpercatinib or pralsetinib. The efficacy in previously treated patients, as you mentioned earlier, is very high. The response rates in patients with RET fusion positive DTC that have been previously treated is still very high with both drugs. In the US, both drugs are FDA approved and can be used even in the first line setting. So certainly in the third line setting. And I think that one thing that this case highlights that's very important is that many of our patients with advanced thyroid cancer are now indeed living for many years because of the effective therapies that we have. So it's not uncommon to see a patient who's had first line therapy, second line therapy, third line therapy, and now we're entertaining a fourth line therapy.
And the second clinical case is a female patient of 67 years old with PTC harboring an NTRK3 gene fusion who has received only 1 prior systemic therapy. And also in this case, when we see that this patient progressed under the first prior systemic therapy, what are the treatment options and key considerations for these patients?
So in patients with that harbor NTRK3 or NTRK1 fusions with progression on prior systemic therapy, we've got great drugs. So larotrectinib is a TRK-specific inhibitor. Entrectinib also inhibits ROS1 and ALK. The experience with thyroid cancer patients is a little bit greater with larotrectinib than in the studies that have been completed thus far with entrectinib. Because both of these drugs are FDA approved in the US, I would generally use larotrectinib as the next therapy for this patient because of the TRK-specific nature of the drug, as well as the fact that more thyroid cancer patients have been treated and we have more published data. And because they're so well tolerated and work so well, patients are on these therapies for a long time. And doing things like going back to work or retiring and traveling with their families, really often resuming normal life.
And I want to thank the audience and the participating expert. Thank you, Ms. Arley, and thank you, Dr. Witt.